I will advance those slides for you.
Great, thanks everybody. Thanks so much, Lloyd. It's great for you to come on with us today. I want to first jump straight into it. We touched on guidelines the last one or two programs we've had. So today we wanted to kind of go into what I like to call the nuts and bolts of the guidelines, how to really put it into place in your office. Because again, it's one thing to know the guidelines, but then once real life hits with the patient, compliance, as you said, adherence, staff members, depending on how many patients you see a day, plays so much of a role. So I'm going to kind of run through a few things today. Focus on diabetes visits, specific diabetes visits, kind of go into why. Triple E your patients. Triple E your MVP is one thing that we definitely want to touch on as well, and I'll go into it a little bit more. We jumped a little fast, but I know we're running out of time. So diabetes focused visits, why? Often we think of, we do diabetes visits anyway. We do it 3 months, 6 months, 9 months, 12 months. Well, diabetes focused visits are really important, but it's very important when the whole clinic, all of your staff, including your patients, buy into it. Now, why? Value payments, where scores need to be where they need to be so that we can keep the lights on. If you work for a large organization, great. If you're keeping up with a private practice, definitely even more so. And we're focused on rural health at this point, where we tend to do have providers that are privately functioning also. So diabetes visits, I don't need to say this, especially Lloyd, your presentation was great today with how many areas you covered. ABCs, we wish that was the only thing to cover. ABCs can take a whole visit. Cholesterol, renal screening, eye exams. We discussed the CHF and cardiology aspects of it, thanks to Dr. Gotti earlier. And keeping in mind, each visit also has medication adjustment, which is huge. It's not just medication, but as Lloyd brought up, is are they taking it? How much are they taking? And what do we need to do to maintain adherence? Review lab values, hyper and hypoglycemia, and referrals. Because again, in today's healthcare environment, you can move over to the next one. You don't only refer, we refer, and you need the notes to come back for it to be completed in that visit. So often the eye exams, the foot exams, cardiology appointments, it's not just referring as much as continuing the continuity of care where everyone's on part of that team. Now, I'm gonna drill something home. We always say educator, educator, educator. So bear with me, but I'm gonna say it again. I like to call it triple E your MVP. The patient is your MVP. If we're on a basketball team and the patient's not shooting, nobody wins. But the patient does depend on the rest of the team. So you have to educate, empower, and engage. Okay, so definitely jumping kind of quickly, we'll just jump here. American Diabetes Association, the link you'll be able to click, or we'll probably send it to you. You can click both American Diabetes Association or Association of Diabetes Care and Education Specialists, which used to be called CDE. We're getting used to the change. Both can let you know, do you have a program in your area? Because again, we know with the guidelines that we should refer, but the reality comes in, are they in your area? Who's in your area? How do you contact them? If you do have one in the area, then that's great. If your whole clinic knows, that's where we refer all of our new diabetics and all of our diabetics on an annual basis, then it's easier to do because everybody wants to do it. But when you're in the midst of seeing so many patients a day, things will be consistent if it's understood, here's where we send it and here's the paperwork. Keep in mind, insurance companies, pharmaceutical companies, vendors, everyone is in a partnership. We want the patient to get better. Okay, so reach out to resources. In some rural health areas, you may not have an accredited diabetes program, but whether it's your insurance companies in these other areas will know a contact, they'll know contract people, or they'll know free websites that may be able to assist your patient, or they can set it up in office. Don't forget, another partner that you have is your self-insured companies. So let's say, I'm just going to use this as an example, Vermilion Parish. Maybe you're a provider in Vermilion Parish and you're on their healthcare plan. Well, I'm using an example. Maybe you're on the Blue Cross healthcare plan there. Well, you may have a large amount of patients from the school board, Vermilion Parish School Board, or the local hospital. That means you have a large amount of that healthcare insurance. Well, reach out to the healthcare company and may even have contacts for you where their goal is a healthy patient. So a lot of times patients don't even know that they're in a program or have a wonderful insurance program, believe, that can support you as well as the patient with resources that can save you money as well as help you educate the patient, okay? Every patient, you can move on to the next one, needs, particularly in a large organization, it's beneficial for them to know the healthcare nurse, the employee health nurse. Often patients say, I don't know who that is. And then I find out that they have 3 for their department. That's the person that usually does the flu shots. Once they connect, often the employee health nurse will take it from there, okay? Okay, thanks for hanging in there with me. Now, what I want to remind you too is keep in mind, educate, empower, and engage your healthcare team. Often you have some diamonds more than often in your clinic that aren't always being used to their fullest. So keep in mind, diabetes is just too much to do alone. Whether you're primary care or not, it's a lot to cover, and there's so many areas and nuances of patients that make a difference. So you want to stay connected to your staff. Now that may be called if you're with a large organization, you may be familiar with what I'm talking about. If not, if so, bear with me. Otherwise, let's do daily huddles. Some people call them huddles, some people call them touch base. That might be over the coffee maker each morning, where all the staff gets together. If for some reason you can't do it with all the staff definitely have a champion that does this every morning. You touch base and say, hey, these 3 patients that are coming today, they are the 3 patients that you know never take the 15 minutes, never take 20, take longer, or patients that have any certain issues. Bottom line is your daily huddles are for the key information that your healthcare provider goal is, whether we're focusing on A1Cs, whichever part of the planning process or whatever you plan to do, just like a patient. When you plan, you do better. That's what the huddle is for. And it's only 5 minutes, touch base, okay? Now, weekly meetings are also great for your clinic. Often we bring up ideas of what nurses can do in the office, and it's like, well, we don't do that in our office. Well, I don't know if my medical staff can do it. Well, they can if we can pull together the team and make each role clear. So if it's clear that when a patient comes in with a meter, as Lloyd suggested, all meters are downloaded, period. If the patient doesn't have the blood glucose in their hand, the meters are downloaded. Well, unless that staff member knows that's the expectation, it won't be done. And if it's done in every time, perfect. But we need the weekly meetings or daily huddles to make that happen. Often providers may say, well, what are we going to do at the meetings? I only have so much time. Right, the meetings don't need to be an hour. They may need to be 15 minutes. And also keep in mind, you have a large referral base. So let's say you have questions related to coronary artery disease. Well, your local cardiologist may have time or may be able to call for 15 minutes and answer questions, or he may have a right hand in his clinic that can come in and talk to you or talk to your staff about heart disease in your patient. Vendors that can talk about glucose monitoring. So use that time to educate your patients, because if your nurse isn't somewhat versed on diabetes, your patients shouldn't be expected to. That's a huge part that your nurses and your staff play. And I'll touch on a few bases with running through this again. Back up one more time, I'm so sorry. Trying to keep it going. Yep. So sorry. Mm-hmm. Keep in mind, maintaining staff, you can go ahead. Retaining staff is huge. I think everyone on this call knows what it's like when you have a nurse that you trained for years that moves on, or when you get a new nurse that you can see a difference in training and a nurse that you may have to train for the next 6 months to get even close to what you had. So definitely you can go ahead and move on. Teaching and pushing your staff to the top of their roles increases retention of top staff members, whether it's a medical assistant or a front desk person, okay? Making sure they're accountable. Feeling accountable means that they're being successful. Now, Lloyd brought up, what to do to motivate. I thought that was so great that you asked what to do to motivate, because often we forget we are the motivators for our patients, okay? So yes, you are a cheerleader. You may not be a very excited cheerleader. You may not be great, okay? But each provider, each staff member, each front desk person is the cheerleader. So keep in mind, a new onset patient with diabetes will feel overwhelmed. And if the patient appears to be calm and no problem, that's still occurring inside. This is the time when we want the patient to feel that they can take care of things. If you've heard of self-efficacy, which is the ability of the patient to feel they can take care of their diabetes, that has to be something they have or they will not be successful. And so that's the time where we want to give them what we have to. So if they're 14A1C, we have to address many things. But we want to make sure that they leave with as few points of what to do. So not, oh, we want you to take care of your diabetes and also do all of these 8 things today. As much as you can be specific and then pull them back in 2 weeks if possible, so that you can go further and you give them small wins. That patient, that's why I love the fact that Lloyd stated the patient came back. That's a patient that was gone for the longest. He knew something was wrong. He wasn't taking care of diabetes. But when the patient comes to the visit and nothing else, great, I'm glad you're here. We need to work on this. Then that way the patient still feels wanted to be here. Because when a patient shows up, they still showed up. They may not have everything together. They're not where they need to be emotionally, possibly, but they're there. So you got to run with it. Now, after we make sure, never forget about the self-efficacy. They have to believe they're going to do it. If they have a long history of diabetes in their family, they probably have a long history of failures in their mind, okay? Now, keep in mind lifestyle is medicine and it's the core foundation for diabetes. Often we think, why am I going to consider lifestyle again? They don't do it. They're not doing it. He's not doing it. Lifestyle is forever. So we're not expecting exercise to drop 10 pounds. We're not expecting exercise to bring an A1C down alone, but we do want to push it. And so that's the reason why, number one, I won't go into it. The pre and post blood glucose readings makes a difference. A lot of the elderly population in rural health, particularly where there's a lot of agriculture, you ate on beans and rice and eggs. Eggs was the extra protein, or beans and rice and 2 slices of bread. And the reason why you had 2 slices is because you were one of the hardest workers. Okay, so keep in mind what you're asking them to do. Don't make it rocket science. Ask them, take out that bread or put half. Now, and then that way they get a chance to say, I did it. Okay, they get a chance to say that. Now, we'll move on to the next section. Yes, okay. Now, leverage your team members, okay? Now, keep in mind how high depression is in the diabetes, the chronic disease population. Well, you want to make sure to cover that to make sure your patient's on his game as much as they can be with working. If it's not done in the EMR, make sure you can provide it on paper by your nurse when the nurse sits the patient in while they're waiting for the doctor to come in. Most EMR, Cerner, Epic, your nurse can start the process where you can just complete and review. This can save you 3 to 5 minutes often, okay? Now with vital signs, when it comes to diabetes, the nursing staff should know it's blood pressure, pulse, temperature, BMI, and home blood glucose readings. Always have to ask. We've had patients that have diabetes 8 years and say, well, my doctor never asked for it, so that's why I stopped checking. And it's normal to slowly forget or to feel like that the patient never brings it in. So in the midst of my other 25 patients, I forget. If your nurse knows, I always ask along with the vitals. And when they have it, I put it on the desk. Some doctors say, if it's paper, put it upside down on the computer keyboard. Other times we'll say to make sure the patient has it in their hand. Either way, it needs to be printed and provided. That's one example. Blood glucose readings, again, as we said, the one thing you want to do is critical thinking. So even if you have different types of meters, if it's printed out, if you can take 2 minutes or a good 60 seconds to review and go, that was up, that's better, great. Ooh, that was high on the weekend. Do you eat more on the weekend? You're helping your patient to critically think. A patient doing well with diabetes management at home is a patient that has critical thinking skills. Okay, and I just want to cover one more. So you have to show them how to critically think. Make sure your nurses know not to just take medications. Often when observing, what is said is, did the medications change? And the patient says, and the patient really has no idea. It's a quick answer. Make sure you always say, how often do you forget your medications? It won't be insulting to the patient. Many patients will say, what? I never forget my medications. I don't check my blood glucose, but I don't forget that. Or they'll say, on weekends, I always forget. That helps the provider to make sense out of why numbers are improving, to make sense of where the treatment plan lies. Foot exams are so important. Foot exams, again, it can take 3 to 5 minutes just to take a patient's shoe off. Sometimes it's just one. Anybody that had patients, different sizes, different mobility levels? No. Request that the patient, make sure your office understands that the patient will take out their shoes or the nurse removes the shoes before the providers come in. And I know we've been trying to do this for years, but it's something that isn't consistent. And that's the benefit of why we need weekly meetings or even monthly meetings to remind that if you're walking in the room and the patient hasn't begun that process or your nurse hasn't, again, 3 to 5 minutes is huge when seeing a patient, okay, when seeing the whole visit. So keep that in mind. Pre-visit planning is also something you may be doing already. In the future, we can also get you some sheets to help you with pre-visit planning where your nursing staff has everything lined up the day before. Again, if you have Cerner, Epic, different EMRs will do a lot of this for you. But if that's an option that you don't, we actually can get pre-visit lists to you that can help you address and make sure everything is covered. With your EMR, if you don't have it, it can be set up where you literally have triggers or stop points that won't let you complete the visit or go further in to your visit without it, okay? And frequent touch points is the last thing at least I wanna cover. As much as possible, don't forget your patient needs to be touched on a regular basis. One of the top basketball teams in the state top basketball team, the coach stated he has more frequent touch points with his team compared to others. So when you see the patient and it's like, whoa, you haven't taken the medicine in how long? What's going on? Your A1C is 9, pull them back in 2 weeks. They're not ready for 3 months. They're not ready for 3 months because you need to work on concealing that relationship first. Okay, so keep in mind when you keep them, yes, 3, 6, 9 months, when they're higher or have unusual hypoglycemia, pull them in. Make sure that you strategically set up diabetes follow-up protocols. If they're a new patient, they come back in 2 weeks, 6 weeks, whatever your schedule can handle. And if your schedule can't handle it, then we can also you can work on areas of how we're gonna make that happen. So on your EMR area, you'll have what type of follow-up it is. You can also set up within your computer with your pre-planning nurse, how you can set up what's due at that visits, reminders, etc. When you schedule a patient, Lloyd, you shared that you did schedule that patient at the end of the visit. At the end of each visit, it's critical that your nurse, your staff, your front desk person knows to give that patient an appointment. Often patients have felt so overwhelmed for the visit, they're like, forget it, I gotta look at my schedule. It's not really a schedule, they just can't take one more thing. Say, hey, how about we put it on this date and you keep it, we'll call to remind you. If that date doesn't work, call us back. This drastically decreases your no-shows, which means saves you time, as well as the patient is still connected because somebody's gonna call them, somebody's gonna send them a text, and then that way is less leakage, or you end up losing less patients because again, you hadn't seen the patient in 9 months, whether it was COVID, whether they forgot the appointment, didn't call, which happens. You didn't schedule them for 9 months, they no-showed or something happened. Well, at that point, the scores have dropped, the patient's not doing as well. And so that's where you want to keep the connection. And if that patient's at the Pokemon game playing and someone says, oh, you haven't seen your doctor in a while? Well, you want to make sure that patient remembers Dr. Lloyd, yeah, Dr. May, that's my doctor, I do have to call her, compared to, well, I haven't seen him in so long, he's okay, but when you keep that connection, the doctor-patient connection is there and is so important for long-term continuity of care. That is often so underestimated, and leakage costs the whole care system a problem. So often it's like, well, what is this about? Me keeping a patient and someone else not getting a patient? No, when the patient stays with one doctor for 3 years, switches to another with something that couldn't be helped, you're starting over, the relationship's starting over. So again, you want to try your best to keep the connections. When I say frequent touch points, that means if the blood sugars are elevated, the patient can't come in 2 weeks, do a virtual visit. Because guess what? You're going to talk to them on the phone anyway. It's your time. And when a patient has a visit, they see it as important when they have a visit. So a virtual visit will work. If you're going to call, it's the same thing. If none of those two work, have the patient fax it in. Yeah, people still have faxes. We still have faxes. So a patient, depending on where they work, a fax may be their only option. Perfect. Then you decide which nurse is responsible for every Friday or this time of day. Call the patients back that have sent in blood sugars after you take a look. But again, try hard to do your virtual visit. It'll be more beneficial to you taking care of it as well as your patient, okay? Because they'll see the importance. Also consider when you have an A1C, I have here protocols. Choose to do a protocol so that your staff, your front desk person knows, oh, the A1C is 9. He's automatically coming in 4 weeks, guys. He's automatically coming in 6. Because it's a team, you're seeing so many patients, you're covering so many bases, everyone should know without asking, oh, doc, did you want him to come in? No, it's understood. A patient that's 9% comes back in 6 weeks. But of course, you drive your protocols the way you want to, but the point is that you definitely want to drive them and have them, okay? And don't forget medication expectations. If you expect the medication to change, to need to be adjusted in 4 weeks, or at that point, you may want to adjust, make a virtual visit or a follow-up visit so that you can titrate accordingly. Otherwise, again, patient can be lost to follow-up, no show, etc. And you can move on. What we can do is reschedule. I think where are we, Dana? Okay, so sorry to kind of run through that. We were going to touch on a few things with Pop Health, but we can save it. When you want to focus on scores in your office, whether on that's foot exams, A1Cs, it doesn't matter. You may choose that your whole team's going to focus on one thing. So you might think, let me get my list, my diabetes list. Well, if you're blessed, Epic and Cerner happen to be the two most robust programs that a lot of people in this area have. So your reports are a little easier. If you don't know how to get your list, whether you want just A1Cs 9% and above, maybe you just want those with creatinines of something, well, talk to your IT people first. If not, I think it's Noble MedLink you can look into, and I know we have a medical liaison from them, Matt might be familiar. Well, you can reach out and they can assist you with pulling in list also. If you have these types of EMRs, Allscripts, eClinicalWorks, and I'm sure if you have others, but definitely these just happen to be some that I was familiar with, but always check with your IT department, okay? Or your billing company. Sometimes docs say, I don't even have an EMR, it's too much, I'm just trying to hold it together. Your billing company knows everything. That's the next person.